so I'm Charles Davis, for anyone who has not met me yet. So procalcitonin, useless in patients with renal disease. So what is procalcitonin? So the name tells us it's a precursor to calcitonin, which takes calcium out of the serum and puts it into the bones, we're told in med school. But procalcitonin doesn't seem to have anything to do with that. There's no known enzyme in the blood to break procalcitonin down into calcitonin, so it might have a function all on its own. So it's produced by many tissues, depending on the source you look at. They say maybe it's produced by all tissues or just all parenchymal tissues. Definitely noted to be produced in the thyroid, adipose tissue, and neuroendocrine cells. So the script goes something like this. So either lipopolysaccharide from gram-negatives or lipoteichoic acid from gram-positives. Some bacterial antigen gets into the serum, activates immune cells to release pro-inflammatory cytokines. TNF-alpha seems to be particularly important for this. That acts on parenchymal cells that release procalcitonin into the serum. There might even be some sort of a feedback effect, but that's not totally clear at this point. So after those bacterial antigens hit the serum, procalcitonin seems to peak about 3 to 6 hours later. So what's all the hubbub with procalcitonin and why is it important? So as compared to some other serum markers of inflammation like CRP or leukocyte count, it shows little elevation in a lot of studies with localized infections, many non-infectious inflammatory responses like severe trauma. Seems to be something about the early post-op hours after cardiac surgery, after a CABG in particular, the procalcitonin seems to be elevated. And with viral infections, it might even be, it's released into the serum, might even be inhibited. Theory is that maybe interferon alpha production sort of dampens TNF-alpha and that prevents the release of procalcitonin into the serum. Not totally clear, but that's a theory out there. So the pitch is that it's more specific when it comes to these serious systemic bacterial infections than these other inflammatory markers. So you might be able to use it to rule out infection and decrease unnecessary antibiotic use. At least that's one of the early pitches. However, renal disease is a pro-inflammatory state in and of itself. So that might be due to uremia. There's some other theories as well. But these patients have been shown to have elevations in their procalcitonin, at least a degree of elevation. So they can make it turn red on our results review. So is the procalcitonin worthless in that case? So this is just a screenshot from one of our patients who's got a procalcitonin. You can see the reference range is below 0.5. And there's this comment that I'd never read before doing this that says if you're below 0.5, you've got a low risk of severe septic shock. If you're between 0.5 and 2, you should probably measure it again, and it should pique your ears. It should say maybe this person's got an infection. And if it's over 2, systemic infection is likely, so you should probably be worried in that situation. So that's kind of our status quo, what we've been instructed to do by our lab with this lab value. So the first study we're going to get into is from the Korean Journal of Internal Medicine back in 2015, the cutoff value of serum procalcitonin as a diagnostic biomarker of infection in end-stage renal disease patients. So it's a relatively small study, so they have 20 patients in this control group. These patients are all on dialysis, either hemodialysis or peritoneal dialysis. And these are patients with no sign of infection at all. So average procalcitonin was 0.5 in that group. So that is kind of right at that level where the value would be turning red in our results review. And these patients who did have an infection or were suspected to have an infection had been started on antibiotics. The procalcitonin was drawn within 24 hours. Average value of 2.95, so well above that secondary threshold of 2, kind of more specific on that end for a systemic infection. So they say that, in patients with end-stage renal disease, because they might have a procalcitonin of 0.5, even without an infection, maybe a threshold of 0.75 for the lower end, more sensitive threshold would be better in those patients. Gives you a sensitivity of 76.2%, specificity of 80%. So I was feeling pretty good after reading that. And then I was told about this study from the pinnacle of all knowledge and culture, Santa Barbara Cottage Hospital, written by a former resident here who's now an infectious disease specialist, and our own Drs. Golgert and Sugar. Sensitivity and specificity of procalcitonin in predicting bacterial infections in patients with renal impairment. So 660 of our patients here with an EGFR below 30. So there's a clinically significant bacterial infection present in 362 patients, that's group A, and that's either local infections or bacteremia, and 298 patients who had negative cultures, but still had a procalcitonin value in the system as a retrospective analysis. A lot to dig into in this study. I'm going to choose to focus on this one chart at first. So let's take a look at the procalcitonin to 0.5 first. So In predicting a bacterial infection at all, it's got a sensitivity of 80%, specificity of only 35%, negative predictive value of 60%. So not great numbers. And then procalcitonin of 2, sensitivity of 60, specificity of only 65, and that's kind of supposed to be our higher cutoff for a more specific number for the procalcitonin. Negative predictive value of 58%. So not great numbers there. Just to give you an idea of the patient population. So in Group A, who were thought to have infections, 219, so 60% of them had a procalcitonin over 2. And in the Group B, it's people without culture-positive infection. 34% of them had a procalcitonin above 2 as well. So not great numbers for procalcitonin. There were some limitations listed in the study, so it was a retrospective analysis, not totally sure if there was concomitant antibiotic use. And this is relying on culture data as well, so perhaps some of these people in Group B who didn't have a positive culture actually did have an infection and they were just culture negative. So maybe some of these people should have been over in Group A. So wasn't feeling great about procalcitonin after that, though I should mention, so there was another chart that I didn't include in here. It said that, so when it comes to bacteremia, the negative predictive value of a procalcitonin of 0.5 was 87%. So pretty good for ruling out infection when it comes to bacteremia specifically. So this study looked at, rather than using culture data to see whether people had infections, they were looking at just sort of the CDC criteria for infections for pneumonia, UTI, and so on. So this is from the journal International Urology and Nephrology from 2014 as well. Procalcitonin's diagnostic value in systemic infections in chronic kidney disease or renal transplant patients. So their stick was that they were very stringent in their criteria about infections. So for procalcitonin of 0.5, they were saying that it's 93% sensitive in their patient population. This total patients was 82 in this study, and specificity of about 80% as well. And with their higher cutoff of 1.5, about 58% sensitive, but 95.8% specific. So pretty good overall. And lastly, another article, everyone's favorite, Wiener Klinische Wogenschrift from German. Procalcitonin in patients with acute and chronic renal insufficiency. So big chart. These first 4 groups, no infection. The last 2 groups were septic. These patients all have different varieties of renal failure. So this first group, not on dialysis, no sign of infection, average procalcitonin of 0.1. These patients here on continuous ambulatory peritoneal dialysis, average a median procalcitonin of 1.1, so well above that 0.5 cutoff. They're thinking that the peritoneal dialysis patients, something to do with the increased intra-abdominal pressure from the fluid, or maybe just the peritoneal dialysis catheter is just like a continuous nidus for like a low-grade endotoxemia, might drive up their procalcitonin relatively higher. These are people who've been on dialysis for less than a year, median procalcitonin of 0.3, and then if over a year, their median procalcitonin of 0.6. So these people would all have a red procalcitonin in the system without having an actual infection, and the septic patients well above that higher threshold of 2, 9.9, 35. And then they also draw attention to another use of procalcitonin. So they trended 2 of the septic patients for 10 days procalcitonin, trended them all the way down to normal. So rather than just using it to diagnose an infection, they're using it as a marker of whether or not you should continue giving someone antibiotics. This is procalcitonin here, dashing gentleman. So procalcitonin can be elevated above 0.5 in patients with a sort of advanced renal disease. So it can be read in the system even without a sign of infection. But if you're using a higher cutoff sort of as instructed by our lab, such as 2, it's unlikely that a patient's going to have a procalcitonin above 2 if you don't have a systemic infection. So that higher cutoff of 2 should sort of perk your ears a bit more, make you worried. And there's a value in trending these values over the day, over a couple days as well, just as a marker of whether or not your antibiotics are working or whether you should continue them. In summary, as long as you use it as described by the lab as instructed, then it certainly has use. At least it's not useless in these patients. So.
Okay, great. So before we get to the vote, I'm sure Dr. Sugar must have some comments. Thank you for coming.
The original impetus for doing the study here was to look at the effect of hemodialysis itself on procalcitonins, because we had a gestalt that maybe it was sticking to the membrane and the pre-dialysis would be higher than the post-dialysis. And that's probably not true. But what we did find, we had a lot of tables in there, but if you looked at the sensitivity and specificity with a cutoff about 3.2, we got about 80% in each of those parameters. So it actually turned out to be a decent test. But renal failure or not, the utility is clearly in following over time. And trending it absolutely does, when looking at bacterial, pyogenic bacterial infections, trending it absolutely does, I think, add something to the clinical management.
I think also a lot of these studies were retrospective, and I think one of the things that I try and emphasize on rounds is that, a single value of procalcitonin that's less than 0.5 doesn't mean that the patient doesn't have a systemic infection, or if it's between 0.5 and 2, you really should be repeating it within 8 to 24 hours. That's the recommendation from the manufacturer. That's the recommendation on the lab result, which no one reads. Excuse me, but it's not often done. And because it's not, and particularly when this study was done here, the retrospective study, it was not done frequently at all to repeat them. I mean, we're getting better at repeating them now, later on if we still suspect that they have a bacterial infection, but back then they weren't. So a lot of this data is based on a single value, I think, which is, and I think it's probably true of some of the other studies as well. Yeah, somebody else had a question? Yeah.
So my question was more with regards to, did your research have anything to do with the background cause of end-stage renal disease as affecting the procalcitonin values? Because I know we had a patient together that had an elevated procalcitonin and had good pastures.
Yeah, that was actually that patient's procalcitonin that I showed, the 2.96. Patient did not have an infection, had good fascia disease, and like this C-ANCA positive crescentic glomerulonephritis. But yeah, I mean, we worked it up because it was above 2. I mean, we were afraid there was an infection, did like a whole bunch of workup. But it depends on the cause. There are some causes that can send it way up, and you just don't know why. They don't know why in the research.
I mean, I think there are inflammatory conditions that increase it. Usually it's not very high. It's usually mild elevations, like your patient was less than 3. But if you have somebody with a procalcitonin of 30, 40, or 100, it's probably going to be a bacterial infection, regardless of whether they have renal failure or not. Yeah.
So I think the other interesting thing about your data were the huge deviations on either side of the mean or the median.
Yeah.
And so I think another question, going to Alan's point, I wonder if we look at these renal patients who are coming in over and over again over years, I wonder if there's somewhat of a baseline with regards to their chronic kind of inflammatory state, and whether, again, it's just emphasizing the idea that it's more probably within the person what's happening with their trend rather than the absolute number that's very helpful clinically.
Yeah, there were several patients who had no infection, but like a procalcitonin of 270 or something crazy.
I think your first paper had a median of 2.5 with a plus or minus of 3.6.
Yeah.
I mean,
Yeah.
whoa, right?
Yeah.
That one looks like.
Yeah.
Like in your research, did you find anything that said like that procalcitonins are kind of like a constant baseline in these patients? Because like kind of what Dr. Sugar was saying, like pre and post dialysis was about the same.
I think that's what Dr. Fitzgibbons was pointing out, I think. But I think a couple of the studies showed that the baseline is close to 0.5 and on average in these patients. So it's probably a little higher than people with kidney disease, with no kidney disease, but it's still not like markedly elevated. In that one study he showed, they recommended 0.75 as the cutoff, the lower cutoff, rather than 0.5, probably for that reason.
But it may be interesting if you see someone who's coming into the hospital multiple times and you notice that they don't have a bacterial infection, they have a procalcitonin of 2.5. I think it might be interesting to see what their prior procalcitonins had looked like in similar circumstances. And I wouldn't be surprised if there is, within an individual, more kind of consistency than we realize.
Yeah, because I know we see that with like troponins all the time in people with CKD, and like we see these like elevations that are similar to prior, and that was interesting.
Well, I think you need to look at this as it's a biomarker, and it needs to be looked at in a specific way, very similar to troponins. You pretty much never order a single troponin, you order serial troponins, and it's kind of the same thing with procalcitonin. One value doesn't really rule it in or rule it out, or specifically rule it out. I don't think any values necessarily rule it in or out, but I think it can be very helpful to add to what you're, the clinical data, the other clinical data that you have, and lab data. All right, so I think we're going to vote now. Procalcitonin levels are of no value in patients with renal insufficiency or end-stage renal disease. How many think that this statement is true? How many think that it's plausible? How many think it's busted? Hey, all right. The moment you've all been waiting for.